To the Eyes Wide Open webinar series. Thanks for joining us today. My name is Kim Hodgson and I'll be moderating today's session, and on the line with me is Dr. Nathan Frank. So we're thrilled that you're here to speak with us, Dr. Frank.
It's my pleasure.
Today he's going to be talking, thank you, going to be speaking to the issue of debunking myths in opiate agonist therapy. So we're really excited to hear the latest here. We've had a terrific session so far. And as I said, this is number 4 in a series of 12 webinars, and you can find the rest of the webinars online at www.preventcrime.ca, and we'll have that link for you at the end. But Dr. Frank, I'm going to turn it over to you. You're going to be speaking, and then I'll be moderating some questions for you at the end. For our participants here, a couple of things. We are recording the session, and it will be posted online on the same website that I just mentioned. You are muted until the Q&A section at the end, and we'll be able to selectively unmute those folks who have questions. But if, in the meantime, if you have questions that pop up, you'll see a chat box on the right-hand side of your screen. Feel free to put the questions in there, and then we can see who's asking them and make sure that we cover them to the best of our ability at the end of the session. And finally, you will be getting a follow-up survey sent to you through email from us. To see how we've done and what other information you'd like. So without further ado, I'm going to hand it over to Dr. Frank.
Thank you very much, Kim. I'm not certain how many folks were assembled just yet, and it's interesting doing this online because I've given multiple talks to assembled groups, and I've always had an opportunity to know who's in the audience per se. And one of the first rules about public speaking is know your audience. So what I would ask of you folks, those who are attending, if you might, just as a practice, into the little chat box, perhaps just give me a one-liner in terms of what it is you do and why you're interested in the topic, and also just a one word in terms of how familiar you are with opiate agonist therapy, whether it be not at all or very informed, etc. And that'll give me a sense as to how to tailor my talk. But while waiting to see those chat things coming up, and I'm hoping I'll be able to see them on my screen, very quickly let me introduce myself. I'm a family physician by training. I became involved in addiction medicine in 1999, and over time started spending more and more of my week devoted to seeing patients in addictions. I now will see patients in one of the Ontario Addiction Treatment Centre's clinics 4 days per week. I see patients in Thunder Bay and Ottawa remotely through the Ontario Telehealth Network. I see patients in Kitchener and in Guelph. And I've seen patients in multiple communities across the province. It is an area that I'm very comfortable with, and it's work that I enjoy doing. I don't see anything in the chat room, so I'll just begin. Let me first talk about understanding addiction, and again, this is where it would be helpful to know just how much involvement each of you has with addictions. But I think, yes.
Yeah, there's some that are coming in the question section. If people could just retype them into the chat room, and that way everyone can hear it and not just the moderator, who's myself. So anybody who's put anything in the question section, if you could copy those over into the chat room, that'd be great. Thanks.
Okay, thank you. Yeah, as I said, it's unusual doing it this way. I would imagine this is the way of the future. But the personal touch is a little bit lost here, so I'll keep my eyes open. And now, actually, I do have both screens going, so I thank you for that, Kim, oh my goodness, okay, I'll just say Kim. Yeah, so getting back to the presentation, I think it's important that we understand addictions, first of all, and again, depending on your level of comfort with the topic, a lot of what I say might be repeated. Then we'll discuss the Methadone and Suboxone, collectively known as opiate agonist treatment programs. I will oftentimes use the word methadone in place of the others, in place of Suboxone. Not that I confuse the two, but simply that for so many years we were we had methadone available to us only, not Suboxone. So I'll often talk about a methadone program when I mean a methadone/Suboxone program. And finally, I just want to dispel myths, because that's the one thing I find, that the biases and the misperceptions when it relates to addictions in general, but also to opiate agonist therapy in particular, the biases and myths are quite prevalent, even within the medical profession. So first things first, I'd like people to accept that addiction is a brain disorder. We need to understand the concept of addiction as illness, and I'll touch upon this a little bit later in the slides. But the example that I usually will pull out when speaking to people who are not sort of comfortable with the notion of looking at addiction as a disease is we'll discuss diabetes. And diabetes is a condition that we all accept as being an illness. It is a condition that one is genetically predisposed to. It is a condition that unfortunately will develop in people who have allowed themselves to abuse, shall we say, their bodies in certain ways, whether it be through overeating or lack of exercise. People who have diabetes will oftentimes be able to maintain their illness without the aid of medications, but others will need medications in order to help combat their diabetes, and these folks will be taking these medications perhaps for months, perhaps for a lifetime. And that is where it equates to opiate agonist treatment programs in addictions, and where we treat addictions as a brain disorder or brain disease. The cost of addiction is certainly well known to everybody, whether in the field or not. The impact upon the person with the addiction, as well as their loved ones and contacts, is quite significant. We do know that in order to feed the need for expensive drugs, crime is prevalent in patients who are abusing illicit drugs. As well, there are certain health concerns up to and including death from overdose, or up to and including illness that is passed through the use of shared needles, etc. So criminality, incarceration, ill health, broken relationships, families are fractured, and obviously the financial cost of addictions is something that I'm sure everybody is aware of. The issue, of course, is those people who would be perhaps a little bit simplistic or misinformed in understanding addictions would say, well, you know, if it's clear to all of us that all these negative consequences are seen in response to use of addictive substances, or also in response to other non-substance addictions, such as gambling addictions and sexual addictions and so on, why does a person persist in these addictions knowing full well the consequences? And of course the answer there is that it is not strictly a conscious choice. All addictions will excite certain pathways in the brain. These are pathways that are evolutionarily meant to be excited. You know, sex, for example, should feel good, and this helps in the procreation of the species. You know, there are a lot of reasons why the brain will respond favorably to an impulse, and unfortunately the brain responds favorably to many of the things to which we're addicted to the point where the reward pathways in the brain become stimulated. And also there is a matter of rewiring, there's a measure of rewiring in the brain such that these pathways will begin to take precedence over others, the more conscious pathways, shall we say. And in fact, one way of looking upon it is to say that these motivational pathways are hijacked by the drug, by the use of the drug, by the abuse of the drug. So addiction is not a choice. It is not a character flaw. Addiction is an illness, and that's a point I want to hammer home over and over again, although, again, I suspect by the fact that you've signed on, each of you is quite comfortable with that notion. I did want to quickly highlight some terminology. Terminology around, people will oftentimes interchangeably use the words abuse, dependence, addiction. Very, very simply and very quickly, abuse of a drug is the use of that drug for a purpose other than what is intended. I mean, alcohol for many people is a good social lubricant, allows them to relax in a social setting, particularly if they have some degree of social anxiety. Alcohol in low dose is safe for most and considered socially acceptable. But when one uses the alcohol to excess, when one uses the alcohol to the point of getting sick and puking and passing out, this is where it becomes abuse. Now, there are a lot of people who will abuse drugs who will never become dependent upon those drugs. And the best example that I always think about, having two university-age daughters, are university students who will unfortunately, in quite significant numbers, abuse alcohol and perhaps other drugs on a regular basis through their university years, but once they graduate, get a job, and enter the real world, most of them will give up this abuse and will not persist in the abuse. It's when a person becomes physically dependent that the issues become significant to us in the addiction world. Dependence, as you can see in front of you, is the impaired control over drug use, and that again has to do with the stimulation of these brain reward or pleasure pathways. One can become physically dependent upon a drug without developing addiction. And the example here I always give is sweet little lady with horrible osteoarthritis and osteoporosis in her spine might be taking prescribed opiates for years and even decades. Over this time, she has become physically dependent upon the opiates to such a point that if one were to abruptly discontinue her painkillers, she would go into withdrawal. She would display all the withdrawal symptoms of the opiate addicted individual, in that she would become achy, her sleep would become disturbed, she might have nausea, stomach upset, diarrhea, runny nose, sneezing. Usually the way we describe opiate withdrawal is to say that anything that can run will run. Hence the diarrhea, the runny nose, the vomiting, the even weepy eyes. So this sweet little old lady who has been using prescribed medications for years and years is physically dependent. But if she has never obtained medications illicitly, if she's never, given her doc a story or lied to her doctor in order to obtain more, if she's never said to friends, listen, can you help me out with some pills, etc., she has not crossed the bounds into addiction. We will suggest, and not we, meaning it's not my idea, but the DSM-4 will certainly suggest that addiction is when there's continued use of a drug or continued abuse of an activity, even when the negative consequences are known. And what defines our patients in the addiction setting is that even with all those consequences that we highlighted for you previously, the criminality, the health concerns, the loss of one's financial freedom, etc., even when all these activities continue and the consequences are clear, the person persists in their drug use. So as I said, that is what we talk about when we talk about addictions. There's one other term I want to discuss, and that is the term with regards to opiates, opioids, painkillers, narcotics, and again, for the purpose of this talk, I might be using these terms interchangeably. Very strictly speaking, opiates are naturally occurring substances made from the poppy plant, and these are morphine and codeine. You can semi-synthesize the opiates, creating, for example, a heroin, or in a high-tech lab, you can create de novo purely synthetic opiates or opioids, such as methadone. So in general, opiates are naturally occurring, opioids are synthetic painkillers, but again, I will often use the terms interchangeably, and I would not fault anybody else for the same. So an example of the commonly used opiates or opioids are shown for you on the screen. I'm hoping you can all see on the screen. In Canada, we have codeine available over the counter, Tylenol 1s, for example, which have 8 milligrams codeine. In the United States of America, they do not have any codeine available over the counter. So unfortunately, for our patients, that is a common source of abuse. The trouble is that because it's a very small amount of codeine in the Tylenol 1, for example, patients will be taking them by the handful. And I've heard of patients taking 50, 60, 80 Tylenol 1s a day in order to get the amount of narcotic or the amount of opiate that they're looking for. But unfortunately, the amount of acetaminophen, the Tylenol base of the Tylenol 1s, is sufficient to fry their livers. So almost surprisingly, it's not the narcotic portion of the Tylenol 1 that does the damage, but rather the Tylenol portion. As we go further on down that list, you'll see fentanyl at the bottom of the list. Fentanyl is a very potent synthetic opioid. that is becoming more and more abused, and unfortunately, given how potent it is, it's becoming more and more responsible for overdose deaths in Ontario.